Welcome back to this week's edition of Freedom and Prosperity Radio, put together by the Virginia Institute for Public Policy, so that when you walk into a conversation, 6 feet, social distancing, of course, you can have an engaging conversation without having to get right up in front of one another. And that in our own special way, we're fighting COVID-19 in the Commonwealth. You can find out more about us at tertiumquids.org or virginiainstitute.org. You can also go back and listen to previous editions of this program on our YouTube channel. Just search Freedom and Prosperity Radio. Our next guest is Senior Research Fellow and Director of Equality Initiatives at the Mercatus Center, which is part of George Mason University. He is Matt Mitchell. Matt, welcome back to the program. How are you doing today, sir?
I'm well. Thanks so much for having me back.
Oh, it's an honor to have you on, and certainly, everything you've been doing at the Mercatus Center has been, terrific, and one of the leaders in thought, and action too, and trying to put it to action. I guess is the hardest thing of all, because it's easy to be a do tank. I mean, it's easy to be a think tank. It's not so easy to be a do tank, and you guys really put some great heft behind economics. Now, you've come up with some research and have written a report on how the politicians, the legislators, as necessary evils as they are, but how legislators can actually be helpful in getting the healthcare professionals what they need regarding coronavirus, correct?
Yeah, and, really probably the first step, and I'm not saying that there aren't some positive steps, but one of the first steps is to just make sure that they're not standing in the way of healthcare providers in doing what they need to do in order to help people.
Which is so often where you find a politician.
Yeah, that's right. Of course, the instinct for anybody is, what can I do? And unfortunately, in the case of government, often, that natural instinct to try to do something can end up being more harmful. But what we've done is identified, at least in the case of healthcare, 3 ways that state policymakers can get out of the way, sort of follow the old physician's rule of first do no harm, and sort of get out of the way and allow providers to offer the care that their patients need and their communities need right now.
It's an interesting dynamic because there's so much being discussed regarding research into what it is, yet the politicians and so much of the resource seem to be going out for a very obvious fear of being sick and perhaps dying from the virus. Although I would imagine better public policy would be to get a grasp as to what it is first, even though people might be clamoring for a public response. Now we see the Javits Center was way more than New York City needed, even though the stories seem to tell a different matter of packed full hospitals without room, and then they open up the Javits Center, and a trickle of people are going in there, and the Mercy ship from the Navy underutilized. So it seems like maybe the resources could be going to grasp what this thing is. How does it propagate without us knowing we have it, and why does it seem to be suffocating us even if we have a lung full of oxygen?
Well, that's true, and of course, all of us are fighting with limited knowledge and limited information here. There's a lot of evidence that better testing, I think, is probably the key to not completely opening the economy back up, but doing it in a much more intelligent way, where you're actually isolating and those people who are most likely to be carriers. But we're all fighting with limited information. And one of the things that we wanted to do was go back and look at, we may not have the best scientific data on what exactly is causing, how coronavirus works, but we do have decades of scientific data on how certain public policies work. And so we looked at certificate of need laws, scope of practice laws, and telehealth regulations to see how they affect people's access to health care, with just the simple idea that, expanding health care is probably something that we are all going to need over the next few weeks.
Oh, without question, there. And these are all things that very simply can be done with the stroke of a pen, and because they're undoings rather than doings.
That's right. Yeah, that's right.
So let's start with the certificate of public need. It is a popular subject here on Freedom and Prosperity Radio. I always feel inclined to re-explain what those are because I so rarely hear anyone talk about them outside of this show and the guests that we have on it. But that's where medical facilities in your neighborhood get to determine if another similar medical facility is allowed to open in a certain geographical area. Am I understanding it, Matt?
Yes, you absolutely are. And of course, what you're hitting on is the most controversial aspect of it. And it's for that reason that they're sometimes called competitors' veto laws. But basically, what it is if you're a healthcare provider in one of 35 states that has these rules, and you want to open or expand your healthcare facility, you want to add a new bed or buy an MRI machine or start offering drug abuse services, you have to go to a regulator and prove to them that your community needs the service in question. Now, the fact that you want to open it would be proof enough in most markets that you think that the community needs it, right? But not so in these 35 states. And so you have to prove that your community needs it. And the remarkable thing about it is in proving that your community needs it, the regulators will turn to the existing providers and say, well, what do you think? And they are allowed to offer their opinion as to why, all things being considered, they would prefer not to have any competition. So
it's amazing.
It's a rather controversial rule, simply just by the nature of it. It's been opposed by FTC and Department of Justice antitrust authorities for decades, both Republicans and Democrats. And economists have studied it for decades and found it really just doesn't achieve the goals that people think that it will.
Well, and was there a good reason at some point for it, or was it really just an old boys protection racket that somebody managed to get enough friends in these states' general assemblies to say, "Hey, protect my six for me"?
Well, it's probably a little bit of both. I will say I talked to lots and lots of state legislators who, as far as I can tell, are extremely well-intentioned, and they really do buy into the story that's told about these rules, which is that they will limit the unnecessary acquisition of expensive healthcare equipment. The idea was that maybe hospitals are in some sort of a arms race with purchasing more and more expensive equipment.
Okay.
But in reality, what it ends up doing is limiting the supply of care. And if you go back to Economics 101, when you limit the supply of any product or service in a market, you're going to tend to raise costs. It's a leftward shift of the supply curve. And forget blackboard economics. We have now data from several decades, and we can compare outcomes in states that have con laws and outcomes in states that don't have con laws. And we find that the data absolutely support what economic theory would predict, which is that a supply restriction like this tends to limit the access to care, it tends to raise costs, and it tends to depress the quality of care as well.
We're visiting with Matt Mitchell from the Mercatus Center. He's got a great piece. We'll link back to it as well on the things legislators, state legislators, we have a reconvened session coming up that begins on the 22nd, can do to foment better health care going forward from COVID-19, should COVID-20 or 21 be even worse. Matt, one of the things I think you mentioned in there as well, less controversial per se, but was telemedicine and the ability to do more things. And we're not talking about the 5G, I can do surgery from across the continent. You're talking about patients being able to see their doctor without having to go somewhere to see their doctor, and therefore giving more doctors an opportunity to serve patients, right?
Yeah, that's right. And so this is basically the idea of allowing physicians to ask you some questions, maybe via video interface. You can describe your symptoms. You may be able to show them what's going on if it's a rash or something that's visible, and then allowing them to prescribe, of course, medicines or some sort of course of treatment. And in the age of social distancing, in the age of coronavirus, where people are actually developing at-home tests as we speak. So hopefully in a matter of weeks, we'll be at a place where you can order a test to your house. You can take it, send it back to the lab, and if you can connect with a provider via telemedicine, they can provide give you some advice, and maybe a course of treatment. The problem is, so it's generally regarded as the wave of the future, and this is exciting stuff. And the federal government has taken some actions to make it easier for physicians to get paid, for example, for offering telehealth services. But what's not quite so known is that many states have requirements that a physician has to, or a provider has to see you in person before they can prescribe any kind of a treatment or course of treatment. And so what we're recommending is, which is what a lot of states have already done in the midst of the crisis, is to suspend those rules or probably eliminate them altogether, because they don't really make sense even once the crisis is gone, to allow physicians to use the technology that's available to offer treatments.
We were just talking to a gentleman in the opening segment of the program that has actual little Band-Aid size patches, similar to the ones they would put on you at a hospital, connecting to all the gear, but because of the cloud and because of app technology, it connects remotely to big machines like that. So you don't have to be lugging around an entire emergency room, but you can be connected via a smartphone app to all that information. So that would make that even easier.
That's right.
Is something like this, though, also got the Pandora's box of, let's go with the colloquial little blue pill and doctors say yes, where you want doctors to be responsible for what they're doing, and you're not just and I don't want to demagogue the very well-worn saw of the opioid crisis, but you seeing where a patient might be able to get a prescription for opioids or Viagra without ever seeing a doctor. Are these laws kind of going back to that kind of mindset, that if you have to see the patient, you may be less likely to just write a prescription for something they say they need?
Yeah, they may have some. They certainly have some origin in that, and that's partially what we're looking at. Is you don't necessarily have to open up the Pandora's box here. You can allow, for example, physicians can be allowed to write prescriptions for anything other than like pain management medications or things like that, where you're really isolating the types of abuses that are possible. The other thing is there's actually, in a surprising number of states, there's a requirement that they're actually whatever the prescription is, or whether there's a prescription or not, there's often a requirement that there be an assistant. Sometimes this is called a telepresenter, that is physically present with the patient during the telemedicine encounter. So,
wow.
That's something where it's like, we're just not allowing physicians to see patients in their home, because there's just, even if you have the technology, you've got to go to some place and have a telepresenter, working with you.
Wow. Yeah, it's kind
of backwards.
Yeah, sure you can do it. We're going to make it horribly difficult, but we're not going to stop you from doing it. That's
exactly.
One of the classic. I grew up in New York City. That's sort of how their bureaucracy operates. Let me ask you this one, Matt. Though one thing that I don't remember what the third item was. I'm looking for it on my notes, but one of the things you mentioned, nurse providers. I found it interesting that the General Assembly here in Virginia, just this past session, had laws on the docket that would take abortion providers and put them in the hands of less than medical professionals. They could be certified boards, nurse practitioners and things like that. Take the other angle on that, though. Could we expand the role of the nurse practitioner and the role of the nurse to have office hours of their own, that they could see patients? Gosh, the last 10 doctor's visits I went to, I spent more time with the nurse than the doctor.
That's right. So, I actually wrote a piece with my father, who's a physician, a board-certified physician, has practiced for several decades in the state of New Mexico, and he took a position that is not, you don't always hear physicians take, but that's that. Yeah, nurse practitioners are, and physicians' assistants and other highly trained nurses are very skilled and have a lot of experience and should be allowed greater scope of practice to practice up to the full, authority of their training. So just to take, an example here, so the National Academy of Medicine recommends that nurse practitioners be permitted what they call full practice authority, and that means that they should be able to evaluate patients, diagnose, order, and interpret diagnostic tests, and initiate and management treatment. Basically, they should be allowed to do what their training permits them to do. And as it turns out, many states do permit this level of authority. 23 states allow this level of authority. The others allow much more limited scope of authority. Often what they require is that there be a physician that has to oversee and approve everything that the nurse practitioner does. And, if you talk to both physicians or nurse practitioners, you find that really what that amounts to is the physician, if once they come to trust the nurse practitioner, they don't really oversee it. They just rubber stamp it. But it does. Yeah. But it does mean that it's a limit on the number of providers who can offer care. Now, the nice thing is, just like as with certificate of need laws, there's variation across the states in the degree of authority that nurse practitioners and physicians' assistants are allowed. And we can use that variation to test what are the effects. And contrary to the claims of some people, we find absolutely no evidence that there is any lower quality of care. There's no more incidents of malpractice or dangerous care or anything like that in states that permit greater authority to nurse practitioners. What we do find is that there's greater access to care in those states that allow greater authority for nurse practitioners.
Gee, the laboratories of democracy doing what the states were supposed to do all along, Matt. Go figure.
That's right. That's right. Yeah.
Matt Mitchell is on with us from the Mercatus Center at George Mason University. There was a third item in your list, Matt, of things legislators could do very easily that could really inspire a boom in the healthcare industry. It seems like that's going to be a growing marketplace. I presume nationalizing them like Andrew Cuomo wanted wasn't that third item.
No, it wasn't. But no, we've actually covered it. It's expanding certificate of need, or eliminating certificate of need laws, especially those for acute hospital beds, expanding access to telemedicine, specifically by getting rid of rules that require in-person visits, and then easing scope of practice laws.
Oh, okay. So, see, I thought I was prescient and just came up with that on my own. I must have read it in my notes and just it got in there like a worm and everything.
Great minds think alike.
Well, it means I have something in common with great minds, or I read what great minds write and I parrot it. Is what Andrew Cuomo said, though, unfortunately seems to be populist, as with most things that fall under the banner populist, dangerous. And I feel like there's a dangerous place we're going to be when VC Day arrives, victory over coronavirus, that we're going to be facing a call to nationalize our hospital systems and nationalize the medical system and do what Obamacare failed to do, which was crash the private medical business and insert the British National Health Services.
Well, there were early calls when the coronavirus hit that, basically to that effect, that saying, this is going to be proof that there's just not going to be any free marketers in a pandemic. And then, the New York Times and the Washington Post started doing some investigative journalism pieces, some excellent pieces showing just how boneheaded the government's response has been to this, at step after step, starting with the CDC insisting that they and they alone should have a monopoly on testing, and then finally, then their test wasn't, once they rolled out their test, it wasn't approved by the FDA, and then it was a big debacle. Nobody else could run the test very well. It wasn't working, and then ultimately, what happened is there were people in Washington State and elsewhere who said, we're just going to roll out our own tests, and we know that the FDA is not going to like this, and we may be taking on a risk, but we're just going to do it, because people's lives are in the balance here. And, they rolled out tests, and we kind of realized, maybe a one-size-fits-all approach doesn't exactly work here. So, I really don't think that this pandemic is evidence that we need to nationalize healthcare or create a one-size-fits-all regulation for the entire, healthcare industry. If anything, it's stronger evidence that we need to have a lot more experimentation, a lot more entrepreneurship, and allowing people to do what they can to help one another.
Well, certainly, when you look at some of the countries that have had horrible outbreaks of this, and I'm talking about not just numerical, but by percentage of populations, you see everything from China, certainly communist, to Italy, which has been socialist for decades, Spain. These are countries, known for nationalizing industries, and you see the damage that it's caused from that. What about the research side of it, Matt? Can we do more to promote that, where it's not just so reliant either on big government or big pharmaceutical to fund research? So, for example, the hot topic is a lot of the medical community is saying we think we may have caught a flaw in their plan on coronavirus, which is that it's not a lung infection, it's a blood infection, more similar to, believe it or not, malaria, which is why the hydroxychloroquine seems to work. But they need to get into it, and right now all the government research is being done in the lungs. What can be done to empower the private research more?
Well, I feel like I'm a bit outside my area of expertise here in opining on that. I'm not entirely sure. What I would say is that, particularly in the midst of a crisis, we have to appreciate the way scientific knowledge advances, and the way scientific knowledge advances sometimes is, sort of grasping in the dark. We have to be comfortable with quite a bit of uncertainty. And you think about particularly where, science kind of interfaces with engineering, and we're trying to develop new solutions. You go back to Thomas Edison, and he says, he didn't invent a light bulb. He didn't discover a light bulb. He discovered 10,000 light bulbs that didn't work.
Yeah. And
so, what we need to do, in my view, is take a little bit more of a permissionless innovation approach, where people are allowed to experiment and try new things, particularly when lives are in the balance, and treat people like adults. If a physician and a patient want to try an experimental treatment because we don't really have a existing approved treatment, then this may be a time to let them do that.
Well, and certainly people said, 2 years ago when the president signed the right to try law into power, they said it could go down in history as one of the most seminal things he does.
Yeah, that's
for that
true.
reason.
That's true, and that's something people, your organization and others have been pushing for, that kind of liberalization in the laws for decades.
That is lowercase l before you all write emails. That's what Matt was talking about. And Matt, I deeply appreciate your visit. I hope everyone is well in your world. You said your father is a healthcare professional, and I hope everyone in his practice. I always feel, these folks, I've been visiting my mother in the hospital, and I see the nurses, and I realize they can't take 2 weeks off after they've been around somebody with COVID-19. So it's been a very very hard road for a lot of those folks who are very much like those firefighters that ran up the stairs of the World Trade Towers on September 11th. And so I hope everyone in your world is okay.
We are. Thank you. I appreciate that. Yeah, my wife always reminds me, I have a PhD, but I'm definitely not the kind of doctor my dad is, who actually saves people. And that is absolutely true. This is I'm more acutely aware of that now than ever.
Well, unfortunately, the body politic needs healing, I think, even more than the body medical. And as you said, the best thing we can do is get the heck out of the way and let the doctors and nurses do what they need to do, almost like a crash scene where everyone's standing around and then the EMTs show up and say, "Get out of the way, let us in here."
That's right.
That is the scene we're in right now. What are you working on at Mercatus Center right now, or is this kind of the focus of it right now?
Well, this is a big focus. Actually, at the moment, I'm looking at some data to see, sort of pinpoint those states that have certificate of need law restrictions on acute hospital beds, how they are expected to, how that correlates with their ability to serve the needs. Mm-hmm. So we're pairing up our data on con with there's a Harvard study that's estimating, kind of looking forward, how many acute hospital bed what the acute hospital bed shortage is projected to be over the next few weeks. And what we're finding is pretty sobering. States that regulate certificate of need laws through acute hospital beds, or acute hospital beds through certificate of need laws, they're expected to have statistically significantly and greater shortage of hospital beds. So, this is really serious stuff. It's not just blackboard economics. This is real life.
Well, and we saw it actually in abstract before coronavirus became a phrase we all knew and knew how to spell, with our mental health beds here in the Commonwealth of Virginia, and some of those things were falling under the same problem.
Yeah, that's absolutely right. And that's one of the things I often try to get people to think about is, if you don't have the political will to eliminate this local monopoly, so for all hospitals, at least do it for the types of procedures that are standing in the way of care for those who are most vulnerable among us. So there's cons for mental health, there's cons for drug and substance abuse, there's cons that are standing in the way of really low-cost alternatives like ambulatory surgery centers that are they don't even make sense under the original sort of flawed rationales. So
absolutely,
there's a whole lot that policymakers can do short of just eliminating the whole program.
And it's so easy. All you have to do is say, "We won't do." It's Congress shall make no law. I know there's a list of something somewhere in Washington that begins frequently, "Congress shall make no law." So, gotta love a government based on that. Matt Mitchell, Mercatus Center. It's George Mason University. Thank you again so much for your visit, and we'll talk to you again very soon.
Thanks so much for having me, and stay safe.
Absolutely. And for all of you, you stay safe as well, and we will reconvene here again next weekend. For all of us at the Virginia Institute for Public Policy, my name is Joe Thomas. Until then, so long, and thanks for all the fish.